I'm Manoj Karmakar. Welcome to ISSPS TV. If you like any of our videos, do remember to click the like and share button. If you are new to our channel, do remember to subscribe so that you can get regular notification of any future uploads. Ladies and gentlemen, for the next presentation, I'm going to share with you our insights into paravertebral sonography and ultrasound guided paravertebral blocks. As we have already discussed, there is some new concepts, but I will try to stay away from it because we need to still validate some of this in clinical practice. But nevertheless, these are interesting times and you will hear a lot more, so you should stay tuned. I will refer to this to this aspect in this presentation. Firstly, I have no conflict of interest. But whenever you see this red star, do pay attention because these are important take-home messages, and I hope you will find them useful. These are, again, the books that highlight many of these aspects of spine, paravertebral anatomy, and if you're interested, I would urge you to consider them. So now, first of all, let's take a look at the history. We often forget about history. Epidural anesthesia was first described in 1921 by Fiddle Pages. Now, actually, if you look at my last presentation, we said Corning actually performed the first epidural injection, although he claimed it was a spinal, because he did not document any efflux of fluid. So that controversy was eventually settled because August Bayer reported very categorically that before he injected the drug, he could see fluid efflux. But then clinically, Fiddle Pages, he is from Spanish military surgeon, once again a surgeon, described epidural anesthesia. Now, when you look at paravertebral, this was described in 1905, almost 16 years before epidurals, by Hugo Selheim from Leipzig in former East Germany. Actually, it was very interesting because I was in Leipzig many years ago, and Bernard was also in the same lecture, and I was talking about paravertebral block, and I put up a slide, this same slide, and I said, this gentleman, do you know who first discovered paravertebral block? None of them knew about it. And it was funny, a guy from China appearing in Leipzig, in the University of Leipzig, and telling them it was actually in these four walls that paravertebral injections were first described by this great man, Hugo Selheim. Okay, let's get on to business. When you look at anatomical considerations, the paravertebral space is a wedge-shaped space. It's bound anteriorly by the parietal pleura, posteriorly by the transverse process and the costotransverse ligament, medially by the vertebral body, the intervertebral foramina. The nerves emerge from the intervertebral foramina or the intervertebral canal and enter the paravertebral space into this wedge-shaped space. So when we perform an injection, we are performing an injection into this wedge-shaped space. This space actually is quite interesting, and as Ken has already alluded in his presentation, this space is actually very vascular. It's laden with fat. There are neurovascular structures. Even the dural sleeve actually comes out of this vertebral canal. And although this is a wedge-shaped space, the posterior intercostal nerves actually emerge from here. And then the sympathetic trunks are located more in relation to the anterior medial part of it, with the rami communicants. So as a repository for local anesthetic injection, I think it is very important because it is a crossroad where not only somatic, but also sympathetic nerves are crisscrossing. So an injection into this space will not only produce somatic block, but also a sympathetic block, which is important for visceral analgesia. Next is in between the parietal pleura and the costotransverse ligament posteriorly, there is an endothoracic fascia. It is interposed between these two structures, as we demonstrated many years ago with this group from by Dr. Pintarik, that it is actually divides the paravertebral space into an anterior and a posterior part. So if you can see this purple incomplete dotted line, this is the paravertebral space. So you have an anterior and a posterior compartment. The somatic nerves are located in the posterior compartment, whereas the sympathetic ganglia are in the anterior compartment. These spaces communicate with one another. So the contiguous spaces communicate with the other space. In relation to the endothoracic fascia, which is this purple structure, you can see the neurovascular structures are lying posterior to it or deep to it, and the sympathetic fibers are located anterior to it. Now, in clinical terms, this is a fibroelastic structure, but we haven't really been able to demonstrate that it really produces any clinical relevance to our blocks. But I think it does play a part in some of the variability of the block that sometimes occurs with these paravertebral injections. And we have described this in the literature. Paravertable ligaments, most of the time we talk about the superior costotransverse ligaments here. This is that structure attached between the neck of the rib and the inferior border of the transverse process above. And then you have the intertransverse ligament. So they, in fact, form the ligament complex, which forms the posterior wall of the paravertebral space. And then the nerve roots emerge from the intervertebral foramina. And so this wedge-shaped space, as you can see here, is anterior to the costotransverse ligament. And laterally, you have the internal intercostal membrane, which is the medial extension of the internal intercostal muscle. So depending on where you perform the intervention, the ligament you see or the membrane you see is different. So sonographically, it is important to understand this. Also, when you perform the scan, you can see here at the level of the rib, as Bernard alluded to, you often see the internal intercostal membrane, sometimes even at the apex of the paravertebral space, like the tip of the transverse process, as Ken mentioned, you will see the costotransverse ligament will usually end somewhere over there, and the internal intercostal membrane starts. This is the paper, a wonderful paper by this group from Korea. Dr. Yang will be discussing many of these aspects in webinar 8. So hold on for those who want to learn more about this new development in micro CT anatomy. He has very kindly agreed to appear in our webinar number 8. But nevertheless, what is very fascinating is they performed a very high resolution micro CT of anatomical blocks of the paravertebral space, and then they rendered 3D images in various planes. Now, I may just, I don't want to take away everything from Dr. Huang because he is the person, but I like to just talk to you about, just mention to you that some of this new observation actually changes our concepts of paravertebral blocks. And some of the injections that are performed in relation to the behind the superior costotransverse ligament or in the ligament complex. And as I will allude to some of that in a moment. Now, if you imagine this is the sagittal cut from that micro CT, and this is a transverse rendition of the anatomy. Now, this is the transverse view at this level, okay, between the two transverse processes. Before I go there, this is what I was alluding to. As you can see here, this is the articulation between the rib and the transverse process. You can see there's a costotransverse space as they defined it, the CT space. Medially and laterally now I can see that there are some ligamentous, which is the costotransverse ligament. So they propose that this may be a conduit for the spread of local anesthetic from one space to another or into the contiguous spaces. Let's try and focus more on the anatomy related to the section B. So this is a transverse cut of the paravertebral space anatomy rendered in real time. This is undisturbed anatomy, ladies and gentlemen. So there's no dissection occur here. We have a block, and the CT was high resolution CT rendered. Now, what you see here is the vertebral body. I'm not sure I can show you the pointer, but I hope you can see the pointer, but never mind. You can see the vertebral body anterolateral medially, and then you have the intervertebral canal and the transverse process or the articular process posteriorly. This structure, I've just colored it so it just gives you a better perception of the contrast of the structures. So you can see the spinal nerve emerges from the intervertebral canal, the dorsal ganglia located here. The posterior dorsal rami is given off, and it divides into its rootlets and comes out through what would be the costotransverse foramina. This is your superior costotransverse ligament, and this is the intertransverse ligament. Let me go back if you can see that. Okay, so that's the ligament that we are talking about, the superior costotransverse ligament. And this is the intertransverse ligament that Dr. Cho and the group demonstrated so eloquently. They also described the superior costotransverse ligament to have a medial and a lateral slit. The lateral slit was more close to where the internal intercostal muscle membrane commenced, and here in the medial aspect, close to the intervertebral foramina. So this is the medial extension of the superior costotransverse ligament into the vertebral body anterior to the spinal canal. The anterior rami actually emerges from this medial slit and enters the paravertebral space. So this is the true paravertebral space, and this is the retro-paravertebral space, or retro-superior costotransverse space. They defined this as the retro-superior costotransverse space, and this is the spinal canal or the intervertebral canal. So this is another space they document. And this is what would be the erector spinae plane. I don't want to go into this discussion because we are talking about paravertebral block, but as you can see here, this probably brings out new avenues of how local anesthetic can actually spread to produce analgesia without entering the paravertebral space. So you can see in a more wonderful demonstration here, this blue structure is the superior costotransverse ligament. It has a medial and a lateral slit. The spinal nerve emerges to give a dorsal ganglia, then enters the paravertebral space through this medial slit, and then the posterior ramus comes out into the superior costotransverse, retro-superior costotransverse space. And this is a view from the inside. You're looking at it from inside the chest. You see the spinal nerve, and this is the ventral rami. It comes out through this medial slit, lies on top of the superior costotransverse ligament, and progresses into the intercostal space lying on top of the internal intercostal membrane. There's this lateral slit between the internal intercostal membrane and the superior costotransverse ligament. So while these are interesting anatomical information, I'm sure it has a lot of considerations, and truly Dr. Cho's demonstration illustrates that actually the paravertebral space anatomy has been redefined, if you may. So this is the retro-costotransverse space in green, and this is the intravertebral space, which is your spinal canal. And this orange to pink is your your erector spinae plane. This is the lateral and the medial slit, while the blue represents the traditional paravertebral space. So where you inject may truly influence how we achieve anesthesia or analgesia. I would leave it at that, and I think we can all ponder about it as to why these are not seen in CT or MRI, as can see in this image. It's actually one of Kenneth's image. You can see here that this is indeed the paravertebral space, but the resolution of MRI in this is not as high as the ones that the Korean group have used. So this may certainly be one of the reasons. But certainly, my take on it is that this may provide explanations for the mechanism behind some of the variations of thoracic paravertebral block injection techniques and injections that are performed into the costotransverse ligament complex or behind it, i.e. like erector spinae blocks. And these are some of the blocks that have been described without a well-established mechanism. And like the erector spinae plane, you have the mid-transverse process, midpoint of the transverse process to pleura block within the ligament complex, injection in the erector spinae again, or a costotransverse block, retrolaminar block, paravertebral and paravertebral laminar block described by a group in Germany, and more recently the novel costotransverse foraminal block. So if you take the concept they've described, actually the costotransverse foramina does not exist because of the space behind the superior costotransverse ligament complex. Okay, I'm going to leave it at that. Now, let's take a look at what is the mechanism of action with the traditional belief of anatomy. Okay, so when you perform an injection in the paravertebral space, it not only spreads to the paravertebral space, but also spreads to the intercostal, the epidural, and prevertebral root. It can also spread via the mediastinal connective tissue to the contralateral side, as we have demonstrated pre-vertebral spread. Now, epidural spread occurs in about 70% of individuals after a paravertebral injection into this paravertebral space. However, it is important to understand that the epidural spread is only a small fraction of the total injectate. It is usually ipsilateral, and it produces ipsilateral anesthesia, and segmental spread of anesthesia is usually greater when there is epidural spread as opposed to when there is no epidural spread. Now, the paravertebral spread spaces communicate with the contiguous spaces through the paravertebral space. So therefore, local anesthetic injected into one space may spread to the space above and below. Now, the role of the costotransverse space, we don't know, but as you can see here, if the costotransverse space were to be hollow and there is a communication, then local anesthetic can surely, as hypothesized by the Korean group, can spread from one level to another. And without retropleural space spread, you can still have spread to the contiguous space through this. Now, these are some rendered CT images after injection. This was a patient who had paravertebral injection using loss of resistance to air for paravertebral block, multi-level paravertebral block for radiofrequency ablation of a liver tumor. What I like to show you this is because look at how the air has, the injected, maybe a cc of air has done. You can see here, there's some retrolamellar space. There is epidural space, which is ipsilateral, the posterior part. There's intercostal spread. There is paravertebral spread and spread prevertebrally to the contralateral side. So you can get contralateral analgesia or effects of the somatic as well as the sympathetic nerves via this route without the epidural route. And generally, you can see it's mostly ipsilateral multidermatomal contrast spread in this case. So it produces ipsilateral somatic and sympathetic nerve blockade. That's what we understand. Now, as ultrasonography and ultrasound-guided techniques are getting more popular, I think we are beginning to understand that ultrasound-guided techniques may produce a different pattern of spread than what a landmark-based technique used to. But I need to first highlight to you what are the data with landmark techniques. As Dr. Chima has demonstrated many years ago, and many of our work also shows that when you perform a single level injection, which say something like 20-25 cc's of local anesthetic like bupivacaine and ropivacaine 0.5%, you'll get ipsilateral dermatomal spread of about 4 to 5 dermatomes. However, the range is more important. You'll see here that it ranges from 1 to 8. Sympathetic blockade was identified using thermographic images, and they are usually greater than the somatic block in the same individual. And this usually doesn't produce postural changes in BP or hypotension. Now, when you look at this, there are obvious limitations with a single injection technique. This is a single injection through a paravertebrally placed catheter in patients undergoing thoracic surgery. And you can see here that the distribution of the radio contrast is quite different. While the 1 and B may represent the ideal spread, but you can see that it's a cloud-like, it is longitudinal, it is a mixture, some spread to the apex of the lung, and so forth. So this produces some variability in the technique. So it's often very unpredictable what a single large injection can produce. And there is no correlation between the block, age, gender, weight, height, or the dose and volume of local anesthetic. So therefore, unlike epidural, if you increase the dose or the volume, your segmental spread of the block may not change. As shown in this, to your y-axis is the number of block segments, and to the x is the dose. As you increase the dose, you see there's very poor correlation. You can see that the correlation diagram, that there's no increase in actually the dermatomal spread with dose or even volume. This is showing you the effect of volume on the number of segments. Also, the onset of sensory motor blockade after a single injection is also very slow. You can see peak onsets take about 40 minutes. So what about multiple injections? So therefore, multiple injections produce more reliable radiological and clinical spread of sensory motor blockade. So therefore, when one wants a wide sensory motor blockade, it is common to use multi-level paravertebral injections. And therefore, when your objective is to produce surgical anesthesia, it is desirable to inject multiple injections. So today, ultrasound is common. In fact, the first report of using ultrasound for paravertebral blocks was not using it to guide needles. It was usually used by this group from Austria to measure the depth to the paravertebral space and then do the usual landmark technique in 2000. Actually, the first description of paravertebral using 2D ultrasound for real-time intervention was actually by this group in the Japanese literature. This group, Dr. Hara and Dr. Shinichi Sakura from Shimane, described it using ultrasound to perform real-time intervention. I will come to that in what they did later. So when you look at sono anatomy, understanding the osseous anatomy is vital. And as we have already discussed, the anatomy varies from one level to the other, upper, middle, and lower. Also, the morphology of the spinous processes and the lamina and the transverse process produces pattern that is very well recognized, as you will see in the image to your right, that the transverse process of the thoracic vertebra are directed backwards, where in the lumbar region, they are more or less horizontal, if you may. This is to accommodate the rib anteriorly. Now, this is important because when you perform a scan, you will see the posteriorly directed transverse processes. Also, I like to point out here that the relationship of the articular processes to the intervertebral foramina or the inferior vertebral notch. You will see here that it is through the intervertebral foramina that the ventral ramus of the spinal nerve emerges. And the inferior articular process is actually directly related to the intervertebral foramina. So what does it mean in terms of paravertable blockade? So if you can identify the articular process, then the intervertebral foramina is just located anterior to it. So this is what I would like you to take. So then let's take a look at the transverse anatomy. When you perform a transverse anatomy, firstly, you have to identify the sagittal anatomy. The transition in anatomy is understanding the transition of anatomy is important. This is an eye-slice view of a 3D volume that we acquired of the paravertebral space. And we slice that volume into 1 millimeter slices from the rib to the transverse process or the costotransverse articulation. So at the bottom right, you can see the ribs. The pleura is very clearly visualized. As you go to the left and upwards, you will see the anatomy change. These are 1 millimeter slices. You will see at the level of the transverse processes, the costotransverse articulation, they become more bulkier. The pleura is less visualized, and the posterior ligamentous complex is now visualized in this intertransverse space. I showed you this image in my previous presentation. So again, as you move from the rib to the lamina, the anatomy changes. And this is something that you have to practice and learn to identify where you are performing the scan. So today you can perform a sagittal scan or a transverse scan. Today, many techniques have been described for paravertebral injections. And in fact, today there are no optimal techniques that are, so each one has its own individual preference. And I will try and describe some of this to you with the pros and cons. If you want to read an interesting and good article, is by Dr. Crediat and their group, which published in Anesthesiology in 2015. This actually enumerates all the different ultrasound-guided techniques using the transverse or the sagittal scan, and using different osseous landmarks with different approaches for needle insertion, etc. So what should you be using? We will try and address some of that in this discussion. So the sagittal scan, as I alluded to, you perform at the level of the transverse process. Usually high-frequency linear transducers are used. And when you perform a true sagittal scan, I like you to take a look at the relationship of the beam to the pleura. Now, this is obviously not anatomically exact, but we understand that there is an anteromedial reflection of the pleura towards the mediastinum. So, but however, as you scan in this area, it is also understood that you can see the costotransverse articulation with the transverse processes, the ligamentous complex with the erector spinae plane muscle group behind, And the pleura, which is usually very fuzzy, this is even with a very high-end ultrasound system. So therefore, this is one of the problems of performing a sagittal scan of the paravertebral space. That means visualizing the pleura is often a problem. And the deeper it gets with the bigger body habitus, it becomes more of a problem. So why is it? We really don't know the exact reason. But as I alluded to, I think if the beam is not at right angle to the pleura, then it might be an isotropy that is contributing. We have also found earlier on that if you tilt the beam slightly outward, which brings it probably more at right angles to the pleura, the visualization improves. So the pleura becomes much clearly visualized. You can still see the costotransverse articulation. But one of the pitfalls of this outward tilt is that you may actually be visualizing the rib. So too much outward tilt should be avoided, because then you won't be doing a paravertebral injection. You'll be doing an intercostal injection. So the sagittal scan is the next option that we do, is the option that we have. And this is indeed the first approach that was described by Dr. Hara from Shimane. They used an outer plane technique. Just to illustrate to you, they inserted the needle outer plane, like so. They performed a sagittal scan. These are images from the paper. They were able to visualize the transverse processes, and they were able to visualize the pleura. But while they were able to delineate the transverse process, the ligament, and the pleura, and they were able to measure the distance. They perform an outer plane injection. Turbulence to injectate was localized at the retropleurally, and anterior displacement of the parietal pleura was first described in this paper. However, it is important to note here that they were unable to delineate the pleura at the level 1, at the T1 level. We will come to that later on. Oops, sorry. So then you have a sagittal scan and in-plane needle insertion. Various investigators from Ireland, Dr. Orion and the group, actually performed a sagittal scan, and they placed the needle in plane from a caudocranial direction, as it is very frequently performed by many operators today. But what they reported is very important, is that they had a difficulty in visualizing the needle as it was advanced. And this is a common problem with performing in-plane needle insertion with the sagittal approach, is that because the angle of insertion is quite steep, visualizing the needle can be quite challenging. So, and if you want to visualize the pleura, then you have a slight oblique twist to it, which again improves or increases the challenge for you. So nevertheless, it can still be used. And whenever I use it, which I rarely do, I often use the bony landmark as a backdrop, so that and then you slowly hydrodissect your way until you start to see pleural displacement anteriorly or expansion of the paravertebral space. And this is a technique that has been used, and you will see anterior displacement of the parietal pleura, indicating your needle has entered the space. So the limitation of this is poor visualization of the pleura and of the anatomy and the advancing needle. But again, having said that, if you are a proponent of this technique and you're familiar with it, then you have a very low incidence of pleural puncture and pneumothorax, as reported in this publication in regional anesthesia that reported more than 2,000 paravertebral blocks using this, where they use chest x-rays postoperatively to document any pneumothorax. They only had 2 in these 2,000 and 2,163 blocks. So it's quite a safe technique. You can also perform outer plane technique with the transverse approach. Now, the transverse approach is the next. Now, this is a approach actually that was first reported by Dr. Shibata and Nishikawa from Japan. And I'd like to present the outer plane approach first, then we go to their description. You can see this is a transverse scan at the level of the transverse process, and the needle is inserted outer plane. Like so, you perform a transverse scan, you acquire the image of the transverse process, and Dr. Daniel Marhofer and Peter Marhofer and the group performed this, and they identified the needle in outer plane, and once they contacted the transverse process, they directed the needle laterally towards the apex. So this was more a lateral paravertebral injections. As you can see, the white bars represent the sensory block, and the blue bars represent the MRI-related spread. You can see that There's a variable spread with the contrast. Even the sensory blockade is quite variable, quite consistent with the anatomical landmark data that I presented. So therefore, you can perform outer plane injections, but visualizing the needle is again very challenging. And this is indeed an intertransverse scan at the paravertebral intertransverse scan. You can see the pleura, the ligament complex posteriorly. And when you inject the local, you will see displacement and widening of the space. This is a technique, this is an alternative technique where, or better to say, this is probably a better technique where you perform a scan at the level of the transverse process. Now you can see the tip of the spinous process, the lamina, the transverse process, and the parietal pleura anteriorly. There are no acoustic shadow to obscure the pleura, and you can see the ligamentous and the complex and the internal intercostal membrane. And the needle is inserted from an outward to inward direction, and is often described as the intercostal approach to the thoracic paravertebral space. As Dr. Shibata has illustrated in his diagram, the needle is introduced from a lateral to medial and placed at the apex of the paravertebral space, and you inject your local till you see turbulence, anterior displacement of the pleura. But actually, the paravertebral space is in the dark side of the moon, or in this acoustic shadow, if you may. We have been using a slightly side variant to this technique for over 10 to 15 years now. We perform many thousands of individual paravertebral injections, and I believe this is our go-to when we do perform these paravertebral injections using a transverse scan. It's an in-plane technique at the level of the articular processes. So instead of using a linear transducer, we use a curved linear transducer because it provides you a wide field of view. And contrary to what most believe, that low-frequency transducers offer poor visibility, poor resolution, I think that is of the past with modern-day ultrasound systems. So we have a routine that you must follow. You start the scan from the level of the rib. You go caudal till you only see the transverse process, or the Dr. Shibata window here. And then you go slightly more caudate till the transverse process disappears. And now you see an osseous element, which is the articular process window. And as I mentioned to you, the intervertebral foramina is located anterior to it. So this is the sequence: rib, transverse process, articular process window. And remember, the nerve emerges and lies in front of the articular process. As you can see here, this is the articular process, or the facet joint here. The nerve emerges. And so this triangular space is the paravertebral space at the intertransverse level. So this is very clear. It is at the intertransverse level, and it's at the level of the articular process. And when you see the ultrasound image, I will come more to that. You will see that this articular process, you can see this hyperechogenic structure, which is the articular process. And then you will see the pleura anteriorly, and this ligament complex posteriorly, which continues as the internal intercostal membrane. So all the neural vascular structures that are in the paravertebral space are located in this wonderful space here. So this is the first window, showing you the various anatomical structures I alluded to: the spinous process, the lamina, the costotransverse junction, the posterior directed transverse process, and the rib. You now go below the rib, you will see the transverse process and no shadow laterally, exposing the apex of the paravertebral space, which is the target for the injection that Dr. Shibata and Dr. Nishikawa described in this apical part. However, if you go slightly below the transverse process, you will see the medial part, which is the articular process. And then you see the entire ligament complex with the parietal pleura anteriorly. And this becomes the triangular true paravertebral space. And this is what we use for our paravertebral injection, injecting into this triangular wedge-shaped space. We do not inject close to the intervertebral foramina. But however, there is emerging evidence that injecting closer to the foramina is clinically beneficial, and I will come to that later. We usually inject somewhere between the apex and the foramen. So somewhere here is where we would guide our needle for the interest of safety. And so this is again to illustrate to you the three sonographic windows that you need to learn to acquire, and I will show you that in the demonstration. And then you can acquire the articular process window. And once you know the articular process, you, in your mind's eye, you would know where the paravertebral space is located. As you can see in this sequence of videos, this is the rib level, this is the transverse process level, and this is the articular process level, where you can see this paravertebral space in this anatomical area here. So this is the triangular paravertebral space that is our target for injection at the articular process level. So demonstrated in the video, at the mid-thoracic level, you can see the rib window. You can see the shadow of the spinous process, lamina, transverse process, and the rib. Yes, a bit of the pleura is visible occasionally with the tilt. Now we go below the rib, you can see the transverse process window. And this is often a case of slight tilt rather than a slide. So once you tilt it slightly further, now the transverse process shadow disappears, and now you can see the paravertebral space in this acoustic window here. So insertion of the needle is also at the level of the articular process. This is our setup. It's usually an aseptic precaution, in-plane injection. And as you will see here, this is another good image of the paravertebral space at the articular process. So this is where the intervertebral foramina is located. The needle is inserted in plane, as you will see in the ultrasound window in the image there. It is advanced towards the apex and somewhere between the apex and the foramen. And then we inject some saline to hydrodistend the space and confirm that there is pleural displacement. This, to a certain extent, also excludes intravascular placement, because as Kenneth has alluded to before, this is a very vascular space. Injecting saline and pushing these veins away, and then incrementally injecting your local anesthetic, you will see the paravertebral space will distend up. There's increased echogenicity of the pleura. This is because of post-enhancement, widening of the space. And in some patients, you can even see the entire ligament complex becomes much clearly visualized. A pearl is that we tend to avoid going close to the foramen for obvious reason. Also remember the dorsal branch of this intercostal artery actually emerges quite close to this. And this can be in the line of fire if you're going very close to the periforaminal area. We've described multiple injections using this approach for surgical anesthesia during breast cancer surgery. Whether it works or not, this for a discussion on another webinar that we will be conducting later on in our series, and where we will teach you how to use paravertebral block for surgical anesthesia, and does multi-level paravertebral block provide surgical anesthesia on its own. So nevertheless, as you can see here, we put T1 to T6. We perform multi-level injection. Today, our practice is to inject T2, T4, and T6 level, 3 levels with ultrasound. Patients are sedated with dexmedetomidine after having received some midazolam during the block. We give them some ketamine also for the procedure during the block placement. They listen to music. They are awake, sedated, and this is the procedure being conducted. So stay tuned. This will be in webinar 9 on the 27th of November. This is a data not yet published, but we are in the process of preparing for publication. This is our experience over 6 years, where we did, in a single unit, we did 430 patients received multi-level or paravertebral injections of various types. Individually, about 1,400 injections were performed. There was a 0 incidence of pleural puncture or pneumothorax. Majority of the complications or side effects were related to the ketamine that we needed during the procedures. Of course, there were some incidences of vasovagal attacks, incidence of vascular puncture, and minor paraspinal hematoma. Otherwise, no major complication. Dr. Takeda from Japan, again, Japan seems to have a good history of paravertebral block. You can see from Shimane, it went down south to Dr. Shibata, and now to Dr. Takeda. I think he's from Sapporo. Anyway, it's an in-plane needle insertion with a medial injection technique using a low frequency. It's a small probe, and you can see here. This actually technique is not novel in some respect, because it has been described by Louis in cadavers, and also been described by Dr. Gautier using the lamina or the articular process, and then direct needle into the paravertebral space medially. So it is an approach where you insert the needle very close to the midline, identify the lamina or the articular process, and guide the needle into the paravertebral space. Now, mind you, this is described as early as 1952. So when folks write that this is a novel technique, I think it just means that they haven't reviewed the literature well. As you can see, in 1952, Shaw described it in the Journal of Medicine that a medial paravertebral technique. Nevertheless, this novel paralaminar technique that Dr. Takeda has described using a microconvex array is interesting. While it is a general practice, I have always taught that we should not go close to the foramina, but Dr. Takeda has changed my practice. It is indeed maybe beneficial in some respect, and I will present some of his data. You can see this triangular wedge-shaped space. The needle is inserted from the medial aspect of the transducer, and because this is a microconvex, it is not truly, it is and you can see the paravertebral outlines, and the needle is inserted using a guide from the medial aspect, and then you place it where the paravertebral space is and look for pleural displacement. This approach produced ipsilateral spread of the contrast in this cadaver study. The spread to the medial aspect of the paravertebral space and the sympathetic trunks was greater with the medial technique than with the intercostal approach. So therefore, medial spread may be more where the real crisscrossing of the nerves and the somatic fibers and sympathetic fibers are located. So what about the sensory efficacy, blockade and clinical efficacy with the ultrasound guided techniques? In this study by this group from Greece, they demonstrated, compared two intercostal approaches, transverse and a sagittal approach, and they found that the transverse technique, there was inferior in terms of the spread to the paravertebral space. There was a slight improved paravertebral spread with the sagittal approach than with the transverse approach. Clinically, this is again a cadaver study by Dr. Syedel and group using different ultrasound guided techniques, transverse, landmark guided, and using different volumes of injections. They found that the landmark technique produced unpredictable spread, as we already know, but the ultrasound guided technique, they used, which was a sagittal but a medial injection technique, higher volumes produced higher number of stained intercostal nerves. That means greater dermatomal spread, and epidural spread was also greater with the medial injection technique, like a paramedian sagittal oblique, compared to an intercostal approach. This is also shown in your the lateral injection can produce variable spread and very variable spread of sensory blockade, as Dr. Marhofer and the group have shown. A single injection compared to a multiple injection was studied by Dr. Vishal Upal and the group from then London, Ontario, where they found that whether you perform a single or a multiple injection, which is 3 injections using a sagittal approach in plane technique, there are no differences in sensory blockade from the T1 to T10 dermatome. So the single injection produced comparable dermatomal spread as a multiple injection. So as you can see here, this looks a little different from the landmark-based technique. But however, these studies they use these blocks for analgesia. Is to be seen if you can do a single injection paravertebral and perform surgical anesthesia. My feeling is that would not be possible on a consistent basis. Coming back for the last part is the paravertable with the Takeda approach, which is the paralaminar approach. They compared intercostal with the paralaminar approach, where they looked at IV PCF fentanyl consumption as their primary outcome in patients who underwent post-thoracotomy analgesia. They performed the intercostal approach versus the paralaminar approach. They found that the paralaminar approach produces greater sensory blockade compared to the lateral approach, whether you test it with pinprick or cold test. The pain scores at rest and movement in the first 24 hours was significantly lower in the paralaminar group as compared to the intercostal group. Also, rescue fentanyl consumption was significantly lower in the paralaminar group. So this indicates that the paralaminar or medial injection techniques may be clinically advantageous. This is another study by a group from the All India Institute of Medical Sciences in New Delhi by Dr. Patnaik and their colleagues. They compared anatomical landmark-based multiple injection to an ultrasound-guided multi-level paravertebral block for surgical anesthesia for major breast cancer surgery. This is probably the first randomized study comparing landmark to ultrasound guidance for surgical efficacy. They found that the surgical success rate was greater with the ultrasound technique. More dermatomals were blocked with the ultrasound-guided patients. There was also less sparing of the T2 and T3 dermatomes in the patients that had received the ultrasound-guided block. So there are less sparing of the T2 and T3 dermatomes in the ultrasound-guided groups. Also, the pain scores post-operative was significantly lower in the ultrasound-guided group. This may be accountable because the dermatomal spread was better. But however, I like you to focus on the number of patients that received rescue analgesia for various pain reported during various interventions like axillary dissection, pain during the supramammary area, during the povidone iodine irrigation of the raw surface. You can see that 80% of the ultrasound-guided group still required rescue analgesia. So this will be discussed more in webinar 9, as I said, but as I said, alluded to the fact that the concept that multi-level paravertebral block can produce surgical anesthesia is wrong. It is not possible. You have to combine it with alternative techniques that take care of the afferent nociception that produce the pain when paravertebral blocks are effective. Also, Dr. Shibata and the group have shown that when you place a catheter with the transverse or the parasagittal approach in a randomized controlled trial, that there are no differences. Whether you perform a transverse or a sagittal scan, the catheters will be in the paravertebral space. So after this long presentation, I'm going to now conclude by saying that today there are different techniques for paravertebral injection. However, there are no optimal techniques described. Success seems to be superior with ultrasound guidance than with anatomical landmark techniques. So this is one reason why you should take up paravertebral blocks with ultrasound guidance, of course, after proper training in these procedures. Medial injection techniques produce greater epidural spread. There's wider segmental anesthesia. Also, clinical efficacy seems to be better than a lateral injection techniques. This is easy to understand based on the anatomy and the afferent nociceptive blockade that you can provide. Large volumes seem to be more advantageous than a smaller volume injection. But then it depends again whether you're performing a single level or a multi-level injection. The single level injections, although they produce comparable dermatomal anesthesia, which are statistically not different, but in the clinical validation needs to come when it comes to providing anesthesia for where multiple injections are required. I doubt that single injections will live up to surgical anesthesia as compared to, say, a 3-level injections, which produce very consistent multidermatomal anesthesia. There is a learning curve. Yes, it is technically more challenging than doing an ESP block, if you may, but it produces very high quality somatosensory block, the afferent nociceptive block that can actually abolish your somatosensory evoke potential. If you look up the data in the literature, there are no other blocks that have been documented that can abolish the afferent somatosensory evoke potential. Even spinals, even epidurals, when you perform somatosensory evoke potential from the, say, the sural nerve or the toe, and you measure them in the brain, you find that with spinals and epidurals, there is actually, patients do not complain of pain, but they are still afferent nociceptive signals that reach the brain. Paravertable block, because of its high quality afferent somatic and sympathetic blockade, produces complete abolition of the somatosensory evoke potential. Yes, pleural puncture is a touted complication, I may say so. And sometimes it is used by scaremongers to scare you away from a paravertebral block. But the evidence in experienced hands is extremely rare, including ours. So I think just because it causes pleural puncture, it should not dissuade you from performing paravertebral blocks. If you perform it the correct way and with ultrasound guidance, I think the incidence is zero, as we have documented. The new anatomical data that has just been published is truly exciting, and I think this will change the way we think. I'm looking forward to hearing more discussion in this area. Dr. Wong will be with us in one of the webinars, so do stay tuned. And so stay tuned in this area. I think this is truly a very exciting area. So I thank you for your attention. I think for now, I think we have to go on to the live demonstration. So since I've shown you all this in extreme detail, I will just do a short live demonstration for you, and then we will call it a day. If you have some questions, you're most welcome to pose it in your Q&A. So just bear with me for a few moments. I'm going to go to our next studio, where I will then do the live demonstration for you.